Good afternoon, everyone. I'm Lee Goldstein. I'm the Dean of the Faculties of Health Sciences and Medicine, and all of us in the Health Sciences schools are delighted to be part of today's World Leaders Forum. I always recognize that no one comes to these just dying to hear the introductory remarks of the first person who comes to the podium. So I'm going to be uncharacteristically brief. Welcome you all here on behalf of Columbia and Columbia University Medical Center, and say how delighted I am that we have such spectacular people here today as part of this program. I'll be introducing Dr. Freed, the Dean, but just delighted to have Ray Suarez from PBS NewsHour, Tony Fauci, head of the NIAID, whose guidance and really shepherding of research and advances in AIDS have transformed the epidemic. Eric Goosby, the Global AIDS Coordinator, who's mostly responsible for the PEPFAR program. Michelle Sidibe, Executive Director of UN AIDS and the Coordinator of the Global Response to the AIDS epidemic, as well as our own Wafa El-Sadr, a Director of ICAP and a Professor at the Mailman School of Public Health, and also a Professor of Medicine in the medical school. There isn't anybody who hasn't been touched by AIDS, directly, indirectly, repetitively. One of my most transformative experiences was when I joined Dr. El-Sadr for a trip to 4 different countries in sub-Saharan Africa and saw firsthand not only the way we and others deliver care, but also the patients who sometimes would walk for days to get that care. The global response to HIV has been truly extraordinary, but in reality, this epidemic has required the extraordinary. I'm just delighted today that we have some people here who are a part of that extraordinary response. At this point, I'll turn the program over to Dean Linda Freed of the Mailman School of Public Health.
Well, good afternoon. It's my great honor to be a participant in today's very important event, I think, and to join in welcoming you all here to Columbia University's World Leaders Forum. One of the roles of great organizations, and I think today's panelists represent great organizations, is to ask the right questions. And today's program, which asks both visionary and, I hope and think, transformative questions, is on a future without HIV/AIDS, dream or reality. It features a prominent and distinguished panel of leaders who Dr. Goldstein already mentioned, who are in the position collaboratively as well as individually to shepherd a dream into a reality. As dramatic scientific advances in the treatment of HIV/AIDS fuel our hopes for the promise of a cure and deaths from HIV/AIDS are on the decline, we progress with very heavy hearts, knowing that worldwide over 30 million people have died from the disease and some 2.5 million new infections occur each year. ICAP, led by Dr. Wafa El-Sadr and anchored at the Mailman School of Public Health, is co-sponsoring today's World Leaders Forum to ask this transformative question of world leaders. Dr. El-Sadr herself is a global leader in HIV/AIDS services, research, and education to a transformative goal. ICAP has supported and led work at more than 1,200 sites across 21 countries around the world and has provided, among many other exemplary accomplishments, more than a treatment for HIV/AIDS for more than 1 million people around the world. It is now my distinct pleasure to introduce today's moderator, Ray Suarez, Senior Correspondent for PBS NewsHour. Mr. Suarez is a Brooklyn, New York native, so we're doubly, triply proud, and the parent of a Columbia College student who has covered local, national, and international stories over the course of a clearly illustrious career of some 30 years. He has authored numerous books, including his most recent work, The Politics of Faith in America, garnering a Latino Book Award in 2007. Mr. Suarez hosts the monthly foreign affairs program, America Abroad, heard on public radio international stations and around the world on NPR worldwide. Please join me in welcoming Mr. Ray Suarez, who will introduce our distinguished panel.
Thanks very much to Columbia for bringing me home to New York and bringing me to this campus where I get to visit occasionally, but my money visits every couple of months. So it is a joy, but a tempered joy, to be able to participate in a conference that even dares to dream about a future without AIDS. My career as a reporter has really lined up with the AIDS epidemic worldwide. As a young reporter, I sat in clinics in New York and Los Angeles with men my age who were sure they were dying very soon, and most of them were exactly right. Or I sat in a clinic in Humboldt Park in Chicago on the West Side that was built just to answer the needs of children born HIV infected, to treat them mostly at that time until they died a very premature and tragic death. But I guess if you do this long enough, you get to tell good news stories along with the bad news stories. So being on a farm in rural Mozambique with a woman hoeing her fields who talked about weighing 75 pounds at one point, but now she's back to producing on her land and expects to live a really long life. Or a woman in Morocco who thinks she's one of the first known AIDS cases in Morocco, now middle-aged, who was able to live long past the life that she expected would be cut very short 20 years ago. When she heard that I was from the United States, one of the first questions she asked me was, "Do you know Wafa El-Sadr?" And I had to admit that yes, I did. So we have a tremendous amount of intellectual firepower on today's panel, and if I read you their CVs, we would be here for the rest of the morning. We'd take one question and then go to lunch. So what I'm going to do is just give you a quick sketch of each of these big name pioneers in the world of AIDS research and in fighting the disease both in the United States and around the world. Anthony Fauci has been the director of NIAID since 1984, and in that same way lines up with the worldwide AIDS epidemic. His career has been carried on along with the march of HIV and AIDS around the world. Not only does he deliver really hard-hitting, thorough teaching on how the world can respond and what the United States should do, but he's also been a standout researcher in the early days of unlocking the secrets that the HIV virus held earlier in his career. Dr. Eric Goosby was long a leader in the fight against AIDS before he became the U.S. Global AIDS Coordinator for President Obama, as a leader of Pangea Global AIDS Foundation from 2001 to 2009. But now with the rank of ambassador, I guess it makes you even smarter as you go around the world and tell people what they ought to know. Wafa El-Sadr is your Columbia homegirl here, but ICAP is dug in around the world, really doing daily heroic work in both in understanding the disease and treating it around the world. And Michel Sidibe was long in the fight before he became the executive director of UN AIDS, working regionally and in the UN AIDS administration before becoming the director overall of the program. I want to welcome you all here in the beautiful Low Library, but also people who are watching this panel live streamed over Columbia's pipes and over the online news hour around the world as well. So you lucky people who get to sit in this gorgeous rotunda get one view, but also we're joined by people who are unknown to us and watching our work thousands of miles away. So welcome to you all. Let's get started. The theme of the recent International AIDS Conference was turning the tide. And knowing how cautious public health people are, I know that even choosing that title must have seemed like an audacious act, or one that could finally be imagined, but would have been audacious before. When we talk about turning the tide, Dr. El-Sadr, what do we mean at ground level, where people live and work and interact with each other?
I think it is true that the choice of the word, of the theme of turning the tide, and actually the theme was turning the tide together. And it's very important to remember that word together. And there was immense discussions about what it means on the ground and what has been accomplished and what are we going to accomplish. There was a realization in thinking about this theme that there are so many tools that are available now, scientific pieces of evidence, interventions that we've discovered that can save the lives of people, as well as methods that could prevent the spread of HIV. And that if we really brought together these interventions and knowledge we have, both in terms of scientific knowledge, but also a depth of knowledge of how to take this evidence into action, of how to work with people on the ground to translate the knowledge into programs and to scale them up to achieve the impact on populations. It is through that kind of the confluence of the knowledge and the action and the partnerships that there was a realization, there is a realization that we have a chance now to turn the tide on AIDS. If we can come together, bring the resources, bring our knowledge together, bring the partnerships together, and work together so we can actually turn the tide and transform this epidemic in our lifetime at the population level. And I think it was the grasp by many people who were involved in the planning of the conference, a real grasp of the importance of the moment, and that this moment was a transformative moment. And we should grasp this moment and mobilize around it so that we can line up what we need to essentially accomplish with the people on the ground who are facing new infections every day with HIV or are becoming ill with HIV. How can we do all of this together and really have that impact on the ground, whether it be right here in New York or in Washington, D.C., or in the fields in Mozambique, that this was what needed to happen.
Why, Dr. Sidibe, is this a transformative moment? There are still thousands of new infections a day around the world, and yet I've never seen this kind of optimism before about being able to really turn down the trend line of new infections.
I think you use the word optimism, and I would like to link to the word you used before, talking about the dreams. I think a leader without a dream, because we have a future leaders here, it is a bureaucrat. It's someone who will not be able to use this transformative moment to go to scale. And when I was talking about zero new infection, zero discrimination, zero death, people told me, Michel, you are naive. How you, as a leader of the world on AIDS, you can talk about 000? I can tell you today, the science, and I'm lucky to have Fauci with me here, the science is showing that it's possible. For the first time, I can say in the history of public health, we have been able to increase so quickly the number of people who are in need of treatment in a few years' time. Just 10 years back, in Africa, less than 50,000 people on treatment. Today, we are talking about 6.4 million. No one was telling us that our prevention program would work. We're just talking about Thailand, Uganda, for years as a good example. Today, we have 56 countries in the world who have been able to stabilize the epidemic, even to decrease significantly the number of new infections. We have been almost broken the, I can say, is broken the trajectory of this infection today. So it is a period, it is a momentum being created which can really help us to say, oh, we are turning the tide. We are turning the tide. And I am positive about that, and I believe that we need to continue to invest because we are showing return on our investment. The results are being produced.
Well, Dr. Goosby, Dr. Sidibe mentioned investment, and 6.4 million people on ARVs in Africa. Half of them are being paid for by the American taxpayer. What's the shape of our investment? Can the United States carry so much of this burden by itself off into the future? And are we getting the kind of help, the kind of partners we want and need as we go forward?
Well, I think that the United States' commitment to sustaining and increasing resources to support both prevention and treatment efforts in the global effort are solid. Both Secretary Clinton and President Obama have made policy-level statements about their commitment to an AIDS-free generation. I think Michelle's comments about the number of new infections going down, the prevention interventions, the condom testing systems that have to come together to meet the populations at highest risk to get tested and move them into staging and treatment if they're positive. The additional drop that's seen with PMTCT, male circumcision, and then the addition of treatment on top of that, we are approaching a moment where the number of new infections that are occurring on the planet will be exceeded by the number of people who are going on to treatment. And that crossing of the lines will precipitously drop incidence curves, much steeper slopes, and we are able to say that we are going to pretty much be at a point where we are rapidly dropping the number of new infections because of the potentiation that will benefit from the treatment prevention contribution. All of that to say that the commitment is real, but we realize that we will not do this just with the United States resources, but that the United States resources remain foundational. We understand that relationship. The challenge is, as Wafa says, is to bring the diversification of different resources that fund this effort, understand what they are, what's the country's contribution, and that's been a struggle to define that explicitly, and then to look at mainly PEPFAR and Global Fund as the big motors of resources, other foundations and bilateral programs contributing as well, to create a diversification of the portfolio of resources in each country, so the likelihood that if one drops off or increases or decreases, it minimizes the impact and will be able to sustain these programs. The United States with PEPFAR came out of the chute with an emergency response to stop kind of the death and dying. As we move from 50,000 people in sub-Saharan Africa on antiretroviral drugs, as Michelle said, now we're at the 6.5 million, about 70% of that being in sub-Saharan Africa. We are at a point where those resources now are much more explicitly understood, so we can hold each other accountable to keep that, sustain that, and to increase it. I think that the movement in that emergency response that moved people from a predominantly inpatient-dominated response, the first time we were seeing patients was when they presented with their opportunistic infections largely, to what is now largely an outpatient response, picking people up earlier in their disease before they develop a hospitalization requiring admission. has transformed the medical delivery systems. They can now see other diseases, but it's also put us in a position where we can take stock and now look at what each country is going to need and have an explicit plan that moves forward. So it's transformative on all those levels and really is reflective of, I think, a sea change.
Yeah, I want just to add to what Eric said, that because your question was a pertinent one. US alone can do it? No. I think we are today in the period where the world is changing. 10 years ago, if you look at what was the cover page of Economist, Africa was mentioned as hopeless continent. And just 3 months ago, if you look at the same newspaper cover page, Africa is rising. We have a growth rate of 6–7%. What we are trying to do today is to bring the debate of shared responsibility, making sure that US alone will not pay, but countries will start also looking on their own budget. You cannot put someone on treatment, for example, for 30 years and thinking that will come only from abroad. The resource which will maintain them will come only from abroad. We are seeing change happening. Yesterday we had a very good meeting with Secretary of State Hillary Clinton, with head of states of Africa, discussing, and we are seeing Namibia paying almost 60% of their own budget, South Africa $1.9 billion now on HIV/AIDS programs. So this change, positive change, is important. We are seeing Rwanda introducing health insurance scheme, which were not existing. So I think it's important to just mention that the debate is shifting. It's not anymore one part of the world as a money and the other part of the world as a problem. I think the paradigm is more complex today. People are coming around the table using AIDS as an entry point to open a new debate, a debate around governance system. It's not just AIDS, global health in general.
Dr. Fauci, you've heard your colleagues talk about treatment and the importance of getting on treatment. Recently, when I was in Johannesburg Central Hospital, one of the great heroes in the fight against AIDS, harried, obviously having a very bad day, said to me, "We've been trying education for 20 years. We still have hundreds of thousands of new infections, and we're never going to medicate our way out of this epidemic." She might be wrong. Given what the other panelists have said, if you lower the viral load in such a way that even people who are not being responsible become less infectious, maybe we can medicate our way out of this epidemic.
Well, I think what you're putting a wedge in here, Ray, is the pitting treatment against prevention, is the subtext, the bit. Okay.
You know, there has to be a little tension in the conversation, doesn't it?
So let me just take a minute or so and get into that, because that's really a very important issue that we all face. It is true. Behavioral change is very, very difficult, particularly when it comes in the background of sexuality and poverty and many other things in people's lives which really impact greatly their ability to, quote, change their behavior. But if you look at the combination of preventions that we have, some of which are biologically related, like circumcision or mother-to-child transmission prevention or pre-exposure prophylaxis, together with the things like condom use, etc., that we already have in play a combination of prevention modalities that clearly have the capability, the tools, to turn around the trajectory of the pandemic. If you superimpose upon that something that we just recently became aware of from a scientific standpoint, we suspected it by cohort studies that when you really penetrate a community and treat people, get the viral load down, the actual incidence of infection in that community goes down, because we know from heterosexual couples that are discordant, one infected, one not, mother-to-child transmission, the probability of transmitting to another person is directly related to the viral load. So if you get the viral load low, below detectable level, there's an extraordinarily low chance. Now, if you say, well, if that's the case, why don't we just treat everybody, and therefore it'll be just treat our way out of the pandemic? That would be a mistake. You have to put them both together. You have to have the combination prevention modalities, both biologically and behaviorally related, and superimpose upon that the very, very powerful tool of what we're calling treatment as prevention. And it's really a beautiful phenomenon, because there were, and I was joking with you, Ray, but there was a tension early on, and we all know that because we were there, about resources for prevention or resources for treatment. Now it's one package that really synergizes with itself. So that's really one of the reasons why we're all excited about the fact that we do see the light at the end of the tunnel. And people ask me, well, how come you all said that? And we were all at the meeting. You said that you could possibly have an AIDS-free generation, and you didn't say that 10 years ago. Well, because we didn't have all the tools, and we didn't yet prove that the tools that were efficacious in a clinical trial actually became effective in the field. And we know that now. The only barrier between us and the goal line is that we know we can put an end to AIDS. The question is, will we put an end to AIDS? And that will be the kinds of commitments that we're talking about at the country level, at the PEPFAR, Global Fund, other organizations, but the ownership of this problem by the part of the companies, that I don't feel overly confident in the sense of, well, okay, we can do it, it's over, walk away from it. But I think if we apply ourselves, this statement of turning the tide together is not just blowing smoke. I think it's a reality.
I think what's also quite unique to the HIV epidemic is that while historically there have been a lot of discoveries, scientific discoveries that unfortunately often sit on the shelf or go in the dustbin somewhere, I think what's been unique about the HIV response and the scientific discovery is how fast they move from discovery phase to actually to action. How fast we take a result of a study and then are able to take it and apply it, and not just implement it in one place, but scale it up for millions of people around the world. And I think that's quite unique about the HIV epidemic. So I'm optimistic, not just by the tools we know already that we've discovered, whether they be treatment as prevention or male circumcision or PrEP, which is pre-exposure prophylaxis. That's when people who are negative can take medicines and stay negative. Is that the ability to take these discoveries and actually take them to action is very unique to the HIV epidemic, which makes us all very optimistic that we can package these interventions together to achieve what we want to achieve. I think another aspect of the HIV response that I also think is quite unique is the transformation that has happened as the health systems. I mean, you can have a wonderful vaccine discovered tomorrow for HIV, for example, but if you don't have a way of bringing that to the country and distributing it and giving it to people and people accepting it and coming to receive it, you'll never have the outcome you want. You'll never have the benefit of a discovery. But I think what's been unique about HIV is because of the scale-up of treatment in particular and also of prevention, is systems are now in place. Systems are in place that can generate demand for some of these interventions. There are people who are well trained. There are facilities that have been renovated and are poised to expand and see more people and provide these combinations of interventions. So the changes in the health system, the changes in the society itself, people much more engaged in trying to control the epidemic in their communities, I think in addition to the scientific discoveries, really offer an opportunity to do something quite different. I was reading recently a report by Dr. Bill Fahey, who some of you may know, who was the architect or one of the architects of the campaign that led to the eradication of smallpox in the 1970s. And what was interesting, and he wrote this, and I'm paraphrasing this somewhat, is he said that the response or the eradication of smallpox was based on a strategy that was rooted in science. It was based on knowing about surveillance, knowing that we have a vaccine, making a vaccine that you didn't need to refrigerate, getting the vaccine out there. But while it was a strategy based on science, it was also the tactics of that campaign were based in culture. And that's very important to keep in mind, that we need the scientific evidence, but we need to root our tactics in community factors and these other psychosocial, societal factors that are so critical and unique to the HIV epidemic. And I think when we bring the science, the scientific strategies, as well as depth of knowledge of these tactical ways that we need to enable these things to happen in partnership with these communities, I think then we have a chance to succeed.
Dr. Goosby, I'm glad Dr. El-Sadr brought up improving medical systems, because the United States has put a lot more emphasis on healthcare infrastructure in developing countries than simply, more than simply supplying medicine, supplying gloves, supplying syringes. You want to make sure it's better administered, and you've gotten a little static over that too. Talk about the changes in emphasis in the United States policy.
Well, I think you've said it nicely. It would be tragic if we infused these resources into these medical delivery systems and did not look for every opportunity to expand capacity, to nurture the ability to identify, enter, and retain patients in care. It's rooted in the acknowledgement that the people that PEPFAR was focused on, the HIV-positive individual, has needs. It's a complicated, progressive, chronic disease that evolve into really having to have a medical delivery system that can take care of the totality of that patient's needs, which include hypertension, diabetes, and coronary artery disease. So the nurse, the doctor, the laboratory, the patient information system, the procurement distribution system that makes it all happen are all essential ingredients to any medical delivery system for any disease. We have embraced that as opposed to shunned from it, and have found that with very little in the way of moving money differently, all boats have risen in a profound way. And I think that it started with the debulking of the inpatient-dominated response. So for any of you who were in sub-Saharan Africa or the United States in the early 80s, but certainly sub-Saharan Africa until recently, you had congested, multiple people on wards with HIV-related illness. That has changed in almost every country we're in. The drop in incidence and the earlier identification and pickup of individuals, the cotrimoxazole, the initiation of antiretrovirals, the understanding of co-infection with TB and getting better at all of those things has dropped inpatient considerably. But the human resources and the kind of infrastructure in the medical delivery system have expanded with it, and we have, I think, not been good at describing that additional benefit, but it is there.
I might say that it's too modest to say it, but this is a result of a phenomenal amount of creativity and commitment on Eric's part, because when he was making these transformations, there was a lot of skepticism that this could be done, and he forged on. So, Eric, way to go.
But on one level, it sets up a virtuous cycle where more people get treated for other things that are not AIDS, which is great, and they are more likely to know their HIV status, which is great. But once they know it, they go on ARVs, and you've now forged a relationship with them that's going to last for decades. And some countries have developed pipeline problems, where a clinic that used to give you your month's supply of antiretrovirals, and you'd take it and come back a month later and get your next month's, now can only give you a week at a time, which means you've got to come to the clinic 4 times as often, spend very, very rare coins on bus fare to get there, find childcare in many cases, leave precious jobs to take a half a day's journey to the nearby dispensary. It's a wonderful problem to have. We're keeping more people alive, but it also shows that the world is hardly awash in ARVs. If we've got half the people who need treatment on it, and even those people can't always get what they need when they need it. What strides are we making, Dr. Sidibe, on drug supply and the pipeline?
I will come back to what just Fauci said. treatment as prevention is very important because for me is a game changer. It is changing completely our way to deal with this epidemic. We will need to address certainly the delivery system, like what I said, and also in developing countries to scale up, we will have to certainly rethink completely our the way we deal with the workforce. It's not possible to wait to have the best trend from Harvard or Columbia to be able to reach the millions of people who are in need of this treatment today. We need to tap on non-conventional capacity. We need to certainly reinforce the interface between service provider and community, making sure that we will have, you were talking about distribution system and others, to rethink completely the treatment approach we have today. The pills we have is too complicated. We need a simplified pill which can be given to people maybe for 2 months, and one pill maybe a day. Why not one pill a month? We need completely to use this a game changer to change completely the paradigm of dealing with public health treatment. AIDS is an entry point, is an opportunity to help us to do that. And I believe that is what we need to start bringing in the debate. A pharmaceutical firm need to come around the table to start thinking which type of pill we can give. And we have to also know that some part of our studies are revealing that 40% of the people who are stopping treatment is due to lack of proper nutrition. Drugs could be toxic. Or we are producing drugs today which are, could be used on areas where people are eating once a day. All those issues are certainly very important to be addressed.
Dr. Fauci, what changes about a disease when it shifts from a death sentence to a manageable chronic condition? Do people worry about it less? Do people fear it less? And are there some important things that the AIDS community has to keep in mind as it talks about prevention?
Yes.
Oh, absolutely. That's one of the things that we face not only with HIV but in other diseases, but is particularly important in HIV, that you become almost a victim of your success when you get a situation where everyone was desperate. And I can clearly remember those days in the early 80s where virtually every patient that we all saw died. It was the darkest years of my medical career and the darkest years of the community, particularly here in New York and in San Francisco and other places, that the motivation for preventing something that was a death sentence, where you saw a substantial proportion of your colleagues dramatically ill, hospice-type situations, that's a tremendous motivation. The problem we need to address now, and that's the reason why the combination prevention, you could never ever let up on that, is that when you see now the ads even, and I always get struck by those ads of the antiretroviral, you see somebody who's buff, healthy, rock climbing, you know, use Atripla. It's true, you can be that way, but that gives the image that this isn't such a bad problem, so we can be a little bit careless. And there are some clear situations where, because of the complacency, we have a problem with motivating people in prevention modalities. We have to stay on top of that in a very, very aggressive way. And this is important too, Ray, because I wouldn't say if, but when we achieve that AIDS-free generation and we put a, quote, end to AIDS, you have to sustain that. What we don't want to see is the curve of the inflection of the incidence to go down, people on treatment, and then when we see that we have things relatively under control, we've learned from syphilis, we've learned from tuberculosis, there's control and there's maintenance of control. So prevention becomes even more acutely important once you get things under control, because you don't want to bounce back in the other directions. That was a very good question that you posed.
Dr. El-Sadr, I've had people in clinics in the field talk about how the idea that you can live and live a healthy life is a really important tool for them to get people in, to get them aware of their status and get them on treatment. But those same buff people who are in the medicine ads may not make you scared of contracting HIV or scared enough to make sure you don't contract HIV.
Well, it's interesting, actually, when we look at the evidence. And, you know, what does the evidence tell us over the past 5 years, for example? What's interesting is with the scale-up of treatment, we substantially changed the landscape, health facilities, communities. I mean, the communities where the biggest business, as you all know, is making coffins and selling coffins, that's gone completely. So there's been this transformation that's happened where people are living better, looking healthier, and so on. At the same time, we're also seeing a decrease in the numbers of new infections. So I want to temper the fear that people have that somehow with expansion of treatment, some people would have... I used to hear this, actually, when we started our very first programs of trying to demonstrate that it's feasible to do treatment of people with HIV in sub-Saharan Africa, and people said exactly the same thing, is, well, people are going to take those pills, they're not going to use condoms, it's going to get worse and worse and worse, there'll be resistant virus, and it's the end of the world kind of scenario. We're not seeing that. What we're seeing is that somehow with the scale-up of treatment, with all the benefits to the individuals themselves who are HIV infected and to their children and their communities, at the same time we're seeing a decrease in numbers of new infections. So it tells me that it's much more complex than this idea of disinhibition, that people, if they don't see people sick in their community, they're not going to behave, have less risky behaviors. I think there's a massive decrease in their infectiousness through treatment, but also, who knows, there also are as well potentially decreases in risky behaviors as well that are noted, and that's been seen in several studies. When people are on these new interventions, you can actually see a decrease in risky behavior rather than an increase in risky behaviors. So the data are mixed, but the population level data are encouraging that with increasing treatment, we're actually seeing a decrease in new infections, and that's in multiple countries in sub-Saharan Africa. We haven't seen this in the United States yet, which is quite interesting. I always try to bring back the US epidemic to the discussion, where we've had probably the same number of new infections annually for the past decade or so. And that's despite, at least officially, access to treatment, pretty much access to treatment. So we do have challenges in this country that get at trying to find everybody who's infected. About a quarter of people who have HIV don't know it in the US. So those are behaviors that we need to change. People need to know their status, feel comfortable knowing their status. And then the issue of this whole cascade of then getting into care, getting on treatment, staying on treatment, so that we start reaping the benefits of these interventions. As well as we have a huge other challenge, which is, of course, dealing with some of our most disenfranchised populations in this country, who feel that they're not cared for, they don't have access to the services are not attuned to their needs. So we have some real challenges to overcome in this country in order to start seeing the same thing as we're seeing elsewhere, the decrease in new infections in the United States that we're now remarkably noting in sub-Saharan Africa and other countries around the world.
Well, Dr. Goosby, what's different about the profile of the disease in the United States when you compare it with the rest of the world?
Well, the United States is burdened by concentrated epidemics, as Wafa said. You've got 1.2 million people infected. The numbers around 47,000 per year new infections has been remarkably stable way back into the early 90s, 93, 94. It's predominant in men who have sex with men, gay white men, gay men of color, women, African American women, Hispanic women, and then you have a really tragic malalignment of delivery system access with injection drug using populations. To create safe spaces so these populations that are participating in highest risk can reveal themselves to medical institutions, be identified and entered safely without fear of being arrested or being revealed to the authorities, quote, has to be repeated and established with each new generation that comes forward. It's not a one-time hit like Tony was saying. You need to be repetitive with this. But you need to be aggressive around it. And we as a society have not embraced the complexity of drug addiction, of the difficulty that gay people have in integrating into our society is still very high in many areas of our country. And the best responses in terms of needle exchange and drug treatment, having, from good people, very strong feelings about the appropriateness of paying for those types of interventions, even though the science is very clear that they are very effective. And when applied, you drop incidence. So I think that we have to be aggressive at looking at where the high-risk behavior is and going backward to identify how that population is identified, entered, and retained in care neighborhood by neighborhood. It's not one epidemic, it's multiple epidemics in a city, in one city. And you've got to, as a system of public health, be nimble and acknowledge that you have to have multiple access points and protect them.
Recently, the head of AIDS Alabama told me that it's one thing to be HIV positive in New York or San Francisco or DC. Yep. It's another thing to be HIV positive in Alabama, where communities are smaller, where treatment is less widely available, and fear of being known as an HIV positive person is much, much higher because of local cultural norms. Is there a coastal heartland, an urban-rural split in the experience of HIV and AIDS in the United States?
I would say generally yes, there is. Both coasts have more sophisticated responses that have been hard in coming. They've been longer working at it. They're more mature. As you move into rural settings, even in states like New York or California, which you would think would have a degree of sophistication and maturity with their responses, you still see that. People afraid to go to the clinic the day that HIV is being seen in the clinic because their pickup truck will be seen in front of it. Having in rural settings, Ray, you're right to say, they went to school with maybe the receptionist, and immediately they feel vulnerable by revealing themselves, even though there's an air of confidentiality around it. Small communities, really everybody does eventually know everything.
You could extend, it's different being infected with HIV in New York or San Francisco versus rural Alabama. You could extend that to be it's different being at risk for infection in those places, because the capability of counseling, the openness of being able to accept a person who's gay, to go into a clinic, to talk to their friends, to ask to be tested, that even gets before you're infected. So it's really a double negative whammy, unfortunately.
Recently,
if I could just say one thing that you make me think of. The one wonderful thing about the medical profession is that nobody, we don't have to make any judgment about the behavior. It's not our job to make a judgment. We're not a faith-based organization or a religious belief system. We have to remember that our main role is to respond to the person in front of us, embrace them, and in every instance, make decisions that are in their best interest. That kind of theme needs to roll out both in rural areas in the United States, in some pockets within cities in the United States, but in many places in sub-Saharan Africa and throughout the world. That kind of creed of behavior is not as prominent in our colleagues who are in the health profession in many of the countries we're in, and is another area that we need to address.
Well, perhaps you wouldn't use the word judge, but you do want to make them stop doing things that make themselves sick and threaten other people with their own deaths.
You do. I think that taking the position that you educate and so they understand the risk to themselves and to others is a central piece of the relationship and the exchange. It needs to be repetitive. That trust needs to be built. But I think that when a medical delivery system start to say that this behavior pattern in this population is acceptable to us and we respond to that versus this population, you've taken a step on a very slippery slope.
I mean, I think it's also important to keep in mind is that we tend to think of risk for HIV and personal behaviors, something you did that's wrong or that's risky. There's substantial evidence from the United States, for example, that when you look at black MSM, for example, and you look at their extremely high risk of getting HIV infected, that actually when you examine their behaviors, their risk behaviors, they tend to have less risky behaviors than non-black MSM. So it's complicated, and we tend to always go and say, you did something, there must be something you're doing that's wrong that got you HIV, which is getting at what Eric is saying. It's much more complicated than this. It's kind of the milieu in which these individuals reside, it's their partners, it's the amount of testing that happens in the community, the number of people around individuals who know their status and their behavior. But we have evidence now that demonstrates that it's not just individual behaviors, that it's often these, what people call structural issues or societal issues or partner behaviors. And I think it's this, the complexity of the epidemic is so interesting to appreciate, and it is quite different based on where you're at. I'm often asked when I'm in Africa, in sub-Saharan Africa, people say, oh, things must be so much easier in the United States. And when I'm here working in Harlem, I hear the opposite, you know. So, and there are lessons learned. I think the epidemic here is quite different. It is a concentrated epidemic with very discrete hotspots. We do know where transmission is happening. We know in whom transmission is happening. And I think in the US we have really a golden opportunity to turn the tide in our country as well by using this evidence and focusing on the populations, engaging them, but focusing on the why are they at risk and trying to stop that rather than simply saying people, you know, stop doing this and stop doing that, because I think often that's part of the answer, but that's not the complete answer. And there are lots of lessons learned from, I always say there are lessons from Africa that apply to Harlem and lessons from Harlem that apply to Africa, and we should be trying to really learn from the response, the global response, which has been amazingly effective, and take still some of the models of care, some of the engagements we've done with the communities in sub-Saharan Africa, and take those lessons learned and try to think about how do we tailor them to respond to something that's happening right here.
Well, Dr. Sidibe, if we look at countries that have managed to turn down the curve of new infections, that have made it a value, a social value to know your HIV status, are there similarities between Uganda and Botswana and KwaZulu-Natal, Senegal, places that have taken their own national approach, but perhaps have some things in common, like taking the guilt, taking the judgment out of what is essentially a medical assessment?
I will say that 3 to 4 common observation we can see in different places. First is that young people stop to be just a passive beneficiaries of our program, and they want to be actor of change. I think that is something very important, because when they are actor of change, they become capable generally to play this interface with their peers and help to change completely our primary prevention approach. That's first. Secondly, I think I saw progress happening when we managed to foster the link between science and social change. I can just say that you can have best evidence, for example, circumcision, and it will not be used if you don't foster the link between science and social change. From Uganda to KwaZulu-Natal, you gave a good example. When I met the king of KwaZulu-Natal and I was trying to convince him to really reintroduce the circumcisions, he told me, you know, the Zulu king, Shaka, stopped the circumcision 200 years ago because he was losing his battle against the English people. And he was thinking that the young people, adolescents who could help him to fight, were circumcised and were not capable to join his fight for 3 weeks. So he just decided to stop circumcision. People are saying, no, Zulu culturally were not circumcised. It's not true. And he said for the survival of Zulu nation is the same reason which is pushing him now as a king to reintroduce circumcision. The day the king of Zulu decided to reintroduce circumcision, it has been a shift completely in the nature of our capacity to access to people for going to scale with those programs. So the link between, I think, evidence, scientific evidence, and social change is very important because like Wafa was saying, sometimes we are focusing on individual behavior when it's mainly about practice. It's about what is happening between the society. It's about taboos, how to remove them. So that is a certain. Other element I saw in most of those places is when we have been able to deal with a conspiracy of silence. In most of those places, one of the major barriers was stigma, discrimination. When we have been able to work with those leaders to break the conspiracy of silence, to make people coming out, to be able to really identify themselves and not be afraid of being rejected, service was used. So I want to say that in many places, the issues is not so much just the evidence and the availability of medical services, is how we deal with this interface. And that is critical.
We have mics in the aisle to take your questions. All that I ask is that they actually take the form of a question. Your voice goes up at the end, implying that you're asking a question and not making a speech about HIV and AIDS. I'm sure many of you are very passionate and knowledgeable, but please ask our panelists a real live question. And while we get people to come up to the mics, one thing I had clinicians recently telling me in D.C. on the occasion of the World AIDS meeting there was that they're struggling to get HIV status to be like blood pressure, your cholesterol number, just another health metric. If they could build down some of the stigma, build down some of the terror of knowing, it would go a long way toward helping them put out the fire where they live and where they practice. What are the barriers to that? If every doctor was told in D.C. or places like it, you know, while you're doing this, do this other test as well. Just add this screen to the screens you're already doing. Is it that hard, Dr. Fauci?
No, it's not. I mean, it could be done. Originally, the exceptionalism that we put to AIDS and an HIV test was because of all of the negative consequences that could fall upon someone if they were found to be HIV positive. That's the first thing. You know, insurances, all the bad things that have happened and in some respects, unfortunately, still happen because of the stigma. Also, the now inappropriate in 2012 linkage to saying that if somebody gets an HIV test, they must be at risk. And what does risk mean? Risk is the bad things that society stigmatizes people against. I think that right now, at least, I mean, I live in Washington, D.C., and we have a study, WAFR and our group, together with the South Bronx, two sister cities, if you want to call it that, between Washington and the Bronx, that we're trying to get over that we get people, you know, aggressively trying to get people tested. And one of the ways to do that, Ray, is exactly what you're quoting, is to make it part of the normal healthcare delivery system. You come in for a glucose, you come in for a hematocrit, get an HIV test. And there will still be some stigma associated with that, but I think the benefit for that would overwhelmingly supersede that.
I do think I'm in agreement, and we're learning very important lessons from the study that Tony mentioned in the Bronx and Washington. I do think we have a ways to go with healthcare workers. And you know, they are part of the society, and they carry sometimes the same preconceived ideas about what this means, what HIV means, and what asking somebody to get the test. And they're themselves very often uncomfortable with talking about HIV or getting the test, or even asking someone if they don't mind getting the HIV test. And I think that's going to take, we're doing a lot of work to try to turn that around, but it's routinizing this process and getting healthcare systems, but providers, whether not just doctors, but the nurses, to feel comfortable with this, the clerk in the front of the clinic, the person in the emergency department, to get everybody to feel this comfort. I think we have ways to go even in this country. And that's a lesson that I think we can learn from sub-Saharan Africa, where HIV has become much more of a routinized test. It's called opt-out, is that people tell you about the test and then they do the test unless you say, I don't want to get it done. So that there's some of these countries in sub-Saharan Africa are really leading the way and trying to get where we want to get to in our own country. But I think we have a ways to go to get our providers at all levels to embrace this as something that's important to the health of the community and the health of their patients.
If their answers have been so thorough that it leaves you totally questionless, I understand, but there must be, yes.
First, thank you all for speaking to us. It's really great to hear from all of you. My question is for Dr. Goosby. Given that Congress has cut the PEPFAR budget this year and this really vital program is facing reauthorization in 2013, I was just wondering, what are your plans for PEPFAR reauthorization, and specifically if your blueprint will include concrete treatment targets?
We have been able to get much better at using our resources effectively. When we came in the Obama administration, there were 1.7 people on treatment from PEPFAR. We're now up to 4.5. We've had essentially flat funding throughout that period, and it's because of our ability to be smarter and more aggressive in moving to high-impact interventions and shifting, taking advantage, reaping the fruit of all of the groundwork that occurred in early PEPFAR to build medical delivery systems that had to be put up that could see only 30 people. That same system, without any expansion of human resources or any of the other elements that make a system work, can now see 300 people. So it's not magic what happened, it was just the convergence of those elements. We will continue to be efficient and get more out of that as we move forward. In addition, the Global Fund now has started those same reform efforts. We put 1/3 of the money into the Global Fund, so we will reap that same efficiency in the Global Fund. The third element is that we are now planning and implementing together in 17 countries with the Global Fund. This will give us a profound opportunity, if I could say it that way, to be efficient, non-duplicative, and focus, as we're doing, on true capacity expansion of community and civil society as well as public sector service sites. So I think that we only are optimistic for the immediate future. I think that the arguments around reauthorization are going to be little. It is still very much a bipartisan effort. I've been relieved at that because the new leadership that came into Congress did not know, didn't have the same kind of collective consciousness of what HIV and the epidemic had done. They are people who are younger, are largely not professional politicians, and were coming in with a very specific cause. They really weren't planning to stay. They wanted to come in, cut resources that the government was spending, and that was the agenda. So the interest in kind of what your program was, et cetera, was something we had to aggressively insert into, and everybody up on this stage have played a role in informing congressional leadership around the importance of the interventions that did start with President Bush and continued with President Obama. The commitment, I now know, is strong, bipartisan, and if the Congress does indeed engage and pass things next year, this probably has a good chance of getting looked at. If it isn't, if there is no reauthorization that happens because Congress doesn't deal with it, we will continue as a program, have the same authorities. It'll go from year to year, so it won't poof even if it's not reauthorized. So I really want you to hear that.
Yes, sir.
Good afternoon, panel. My name is Arnold Gans. I'm an alumni board member of Mailman. My question, it was only mentioned once, nutrition. So my question is, how important is nutrition intervention, A, in the treatment, B, for relapse prevention, maintenance, specifically protein intervention?
Well, I could just say very quickly, nutrition is critical. You cannot give the antiretroviral medicine effectively on stomachs that are not getting food, full preferably. People don't tolerate it well, and you end up interrupting or stopping therapy because the patient doesn't tolerate it on almost a local mucosal level. So nutrition is critical. The immune reconstitution is blunted in nutritionally depleted individuals. We've seen that really in children and adults throughout the world. India was the first place we saw that, and the recognition that even small amounts of vitamin A and trace elements really do potentiate the immune reconstitution response. So we see it as a critical piece. PEPFAR pays for a lot of nutrition.
Yes.
Hi, I was surprised. First, I want to say thank you for your comments and your thoughtful discussion. I was surprised, given the rates of HIV, both in this country and abroad, among adolescents and young people under the age of 30. There was very little mention outside Mr. Sidibe on the distinct prevention needs of adolescents and young people. And I'm wondering if you all could address that, both domestically here in the U.S., but then also abroad, whether through PEPFAR or otherwise.
Good question.
Well, adolescents are different, if I could answer that. And they do require a different approach to identify them as well as retain them over time. This city and Donna Futterman's work has applied globally, and it's the same basic issues that we see over and over again. PEPFAR is just getting to the point where we realize we need to develop specific strategies for the adolescents in the populations we've already interfaced with. So we're catching up with that.
I think also there have been some interesting models of care for adolescents, and particularly for those not just who are identified when they're adolescents, but those who are children with HIV and are aging now into adolescence, which is, they have other challenges. They didn't acquire HIV sexually, but behaviorally or sexually, but they acquired it through mother-to-child transmission. Was just recently visiting the program that ICAP supports with PEPFAR support in Kenya, for example, and saw fantastic peer educator groups of adolescents, many of them with HIV themselves, who have disclosed and are now rallying together to help shape programs that are particularly suited for adolescents, not just for caring and treatment, but also for prevention.
Dr.
So
Sidibe.
Yes, I think it's very important question, and I was mentioning that today children and particularly adolescents, they don't want to be considered as a passive beneficiaries of our program. They want to be actors. The world is changing completely, and we had a very good experience. I crowd out AIDS, and which was the first time when I tried to ask to my staff that I'm tired to see a policy and strategy which are developed in UNAIDS office for young people when we have today a different means to communicate with them. Why we don't crowd out AIDS? Believe me, 5,000 to 6,000 young people, adolescents, connect themselves through the new media mechanism, communication mechanism, 70 countries, and they came out with their own policy, and which has been presented to our board as a young people policy. And you know what is coming out of that? First, they are calling for universal sexuality education. They are saying that you are completely missing the point. You will never have a sexuality education today which is tailored for Mauritania and sexuality education tailored for US. The world is flat. Communication is happening in different way. Those young people are communicating. You need to start thinking about how sexuality education can become universal. Two, how you are empowering young girls to be able to negotiate their sexuality in a responsible manner. That is so fundamental, to use the education system to shift completely the paradigm. Third, what resource are you putting in all the funding you have? I'm asking, for example, PEPFAR, Global Fund, which percentage of resources are going to young people to empower them, to make them part of this change we're talking about? Those are fundamental aspects which are coming from this consultation, which is a very important shift in the paradigm we are having.
Yeah, there's a positive spin-off in the success that we've had, and I'm speaking purely from a research standpoint about the resources that go into pediatric HIV, because back before the dramatic results in the prevention of mother-to-child transmission, essentially all of the resources that were research resources went into preventing mother-to-child transmission. Right now in this country and in some developing world countries, including sub-Saharan Africa, the incidence of mother-to-child transmission has gone spectacularly low. In fact, I brought up the point in my talk in Washington this summer that the people in the audience couldn't believe it, that in Washington, D.C., which has the highest prevalence of any city in the country, actually hasn't had a mother-to-child transmission in that city since 2009, which is good news. The reason I bring it up is because now we can shift our resources to looking at the adolescent situation. We've done such a very good job in blocking mother-to-child transmission here in the United States and doing even better in the developing world.
Yes, ma'am.
My question is also about resources, and it's for any member of this terrific panel. Part of turning the tide means maintaining millions of people in dozens of countries on antiretroviral treatment for decades, right? And even if we, looking in the short term, we've talked about reauthorizing PEPFAR, but looking further down the road, you've alluded on the panel today to diversifying resources, diversifying funding streams. How do you see it playing out? How would this diversification happen? What are the prospects for reducing costs through pharmaceutical improvements along the lines of what Dr. Sidibe was talking about? I would love to hear your thoughts on that.
That's a question that we could spend another whole seminar answering, but somebody do it briefly.
Well, Eric said it.
Eric, yeah.
I did.
Yeah.
No.
Can I add something? I do think that there's a limit to efficiencies and sharing of, I think that a lot has been done to achieve efficiencies and to do more with less and to expand the pie as much as possible, to try to do better with what we have. However, I think it would be naive for us to think that this is a long-term investment and needs to be a long-term investment by wealthy countries like ours for many, many years until we get to the end of AIDS. I mean, I really think this is a commitment, as we've made other commitments for other issues that many poor countries around the world are facing. And I think we should be prepared that that will happen and needs to happen, rather than at the same time we're trying to gain efficiencies and bring the prices of drugs down and so on. But I do think this is a substantial, and should be conceived as a substantial long-term commitment by, hopefully by the US government as well as other wealthy countries around the world. I think also it has been underestimated, the investments that these countries in the South, the poor South, have actually invested in these programs from day one. There's this perception somehow that the Global Fund and PEPFAR is just the money that, and magically all the success has happened. There's been a tremendous investment by the countries themselves. It's their facilities, it's their workforce, it's their institutions that have been investing the people and the graduates and so on. And I think we've enabled it through the external assistance to be able to get to where we're getting, but they have substantially invested as well. And now we're trying to kind of put numbers to those investments and increase those investments. But I am not naive enough to think that somehow over the years that this responsibility for tackling the epidemic of our generation is going to be able to be fully, the burden will be fully carried by some of the poorest countries in the world.
Dr. Sidibe.
I think a point is very important one. I remember saying in Washington that ending AIDS is not free. It is not expensive. It is priceless. I said that because at the end is the life which are in balance. We are very happy to have 8 million people on treatment, but we have to remember, like you said, in 2020 we'll have 30 million people in need of treatment. And most of those people who are on treatment today, they are in first-line treatment. And we have been working very well to reduce the price of first line, thanks to all the effort of people who are around this panel. We reduced from $15,000 to $80. But we have to move again back to second line, third line. And what we will do, I think that is a very important question. Secondly, we have to continue to encourage countries to be part of the process of taking some part of the burden. I was just saying that I produced a report, the dependency crisis. 80% of the people to 85 who are on treatment based on drugs coming from India. Thanks to India. But if tomorrow we have a market failure because they want to move out of this production line to go to another drugs, and could be diabetes or whatever, what will happen to our people? We have another line which we need to explore is 81 countries have been increasing through our continuing advocacy by 50% their own resources on treatment and AIDS programs during the last 3-4 years. We need to continue with that one. We need to make sure that we have an investment case, business plan for those countries to make sure that this transition, moving from where we are to long-term thinking, will happen. If not, it will be a serious problem. We have a roadmap for 2015, having people on treatment. We have, thanks to their work, we have guidelines for early treatment. We have guidelines for pregnant women, WAFA and others. But all of that is very good. But the risk you mentioned is critical one. 7 billion gap, and this gap is killing.
Do you have a quick, brief question that one panelist could answer?
Yeah, it's for Dr. Fauci. It's kind of about the research side of a possible HIV vaccine, or if it exists already. But my question is about how close it is to becoming something similar to like an HPV vaccine where you give to adolescents. And is it like the technology or the stigma that's attached to having to have the HIV vaccine? Or is it some characteristic of the HIV, the virus, that makes it a challenge to target? And if you had developed a vaccination, would you choose to go more the treatment methods or the screening methods versus vaccinating before as prevention?
Would that we had the opportunity to worry about the policy that we would use if we had a vaccine. Having said that, the answer specific to your question is that unlike other infectious diseases, where when you develop a vaccine, you tend to try and mimic with the vaccine what the natural infection does and the responses it elicits, because almost all infections, but even the deadly ones like smallpox and measles and polio and others, that even though a certain percentage of the people die and there's a degree of morbidity, at the end of the day, the body ultimately makes an immune response that totally rids the body of the virus and gives you what is usually lifelong protection. Unfortunately for us, that's absolutely not the case. The body does not respond immunologically in an appropriate way to contain HIV, which is the reason why there are no spontaneous cures of HIV. So having said that, what I'm saying is that the challenge now is really a scientific challenge, not an implementation challenge, not a policy challenge. And it's good that you brought that question up in the light of what we were talking about, tools that we have that we just need to implement. A vaccine is a tool that we don't have yet. I believe we will have it because a couple of years ago we had a proof of concept trial that showed that you can actually protect in a modestly small number of people, but you still could protect with a vaccine that we tried in Thailand several years ago. So it really is a scientific challenge. Once we get it, I think we can just vaccinate at-risk people, and I wouldn't be surprised by that time that we would be vaccinating anybody like we do at hepatitis B. That's what I would like to see. If we had it, it would be a hepatitis B, HPV type thing.
My timekeeper, let me get facial. Can I take this last one, or do I have to wrap it up? Okay. Make it elegant and brief.
Absolutely. Thanks to the panel for this discussion, and my question actually follows up very much on the last one. I really appreciate the discussion on a future without HIV/AIDS, but for those of us who are living with HIV, there won't be a future unless we have a cure.
Yeah.
And so I wonder how important it is that we continue to fund research for a cure, recognizing what a scientific challenge that is.
Well, a very short but precise answer is that we are very committed from a research standpoint to find a cure. It's a daunting challenge because of the nature of HIV and how it integrates itself into the genome of a cell. And you want to be careful that you don't have a cure that's worse than the treatment that we have. But in direct answer to your question, we have a substantial amount of resources and commitment that we are not only putting into a cure, but that we're increasing. So if you look at the relative priorities from a research challenge, the two important ones are vaccine and a cure. And as Michelle mentioned, long-acting drugs is another one that we really need to do.
Yep. Thank you for your questions. Thank you for your presence. And the victories that are being won in this battle are in no small measure thanks to the efforts of the people on this stage. So please thank them as well.
Thank you. Thank you.
I will end. Let me just end with my usual advocacy. By 2015, we can have a generation free of HIV. We need you in this battle. I think it will be the beginning of the end of this epidemic. We have been launching a global plan, and today we have 22 countries who are mobilized with PEPFAR to make sure that it could be possible. WAFA was the science behind all of that, and we, of course, Fauci also. And it will cost $150 to stop the transmission. And if his baby is born with HIV, it will cost us minimum of $300,000 only to treat. So let us make sure that we don't have babies born with HIV by 2015. Thank you very much.
So on behalf of Columbia University, I cannot thank all of our speakers, and particularly our lead questioner today, for what has really exemplified for the rest of us why leadership matters and what 21st century leadership looks like. We started out by saying the asking of transformative questions, and the vision of a better future is key to our leadership, linking science to social change. But what we've seen is the demonstration of all the elements of leaders in themselves and leaders of institutions pulling together toward a collective goal for many sectors, with an underpinning both of knowledge and a commitment to science, a commitment to the core values that we share, and a commitment to bringing science into impact. Thank you all so much.